because I listened to the first two talks and they were really good. And one of the things I liked about it was they had a lot of pictures, and I should have put more pictures in, especially for a patient audience, and I didn't. So it may not be it may be more boring than those, but it's short, so. Yeah. Yes, yeah. I want to thank Kelly and everyone for inviting me. And we're going to talk about the Parasarcoidosis syndromes for a few minutes. Here's my disclosures. And there's been kind of a paradigm shift in terms of the way doctors have thought about sarcoidosis over the last 10 years or so. Before about 10 years ago, sarcoidosis was a disease of granulomas, and the granulomas got in an organ, and they did something bad to an organ, and so the lungs got bad, or the skin got bad, or the heart got bad, or the brain got bad. And that's still all true, that can happen. But what we found is there are a whole lot of other problems that can happen to sarcoidosis patients which very significantly affect their quality of life, but are not specifically due to granulomas in an organ. And we refer to those as parasarcoidosis syndromes, which I'm going to define as symptoms or dysfunction in sarcoidosis not directly related to the deposition of sarcoid granulomas in a specific place. And there are several of these syndromes, and here are some of them. Vitamin D dysregulation, erythema nodosum, small fiber neuropathy, fatigue, cognitive decline, pain syndrome. So we're going to briefly talk about all these. First of all, what causes these syndromes if it's not the granulomas? We don't really know. But what we think what happens is there are a lot of chemicals and molecules in the body, inflammatory molecules that are involved in making the granuloma. And the granuloma itself spews out all sorts of chemicals. And we think these other chemicals probably travel systemically in the blood to various areas and cause problems not directly related to where the granuloma is positioned. And that explains all these, we think explains a lot of these syndromes. One of them is disordered vitamin D metabolism. One of the white blood cells in that granuloma, which Dr. Meyer showed you, one of those white cells in that ball of white cells that make the granuloma is a macrophage. The macrophage is the name of one of the type of white cells. And it has an enzyme in it that gets turned on. When it gets turned on, what it does is it converts the inactive form of vitamin D, 25-hydroxy vitamin D, to the active form of vitamin D, 125-dihydroxy vitamin D. The bottom line is that these granulomas spew out chemicals which cause a conversion of vitamin D to the active form, which causes increased urinary excretion of calcium, kidney stones, kidney damage, and even kidney failure. If you look for a granuloma in the kidney, you may not find it. It has nothing to do with that. It has to do with vitamin D being turned on by the inflammatory system. Another one, which Dr. Rosenbach just talked about, is Lofgren syndrome, where the patient develops these skin lesions. These are they're called erythema nodosum. They're violet to red lesions. You just touch them and the patient winces in pain, usually on the ankles or the feet or the shins. Does anyone I bet a lot of people have had them. Raise your hand if you've had them. So several people have had those. If you biopsy those, guess what? There's no granulomas. But then what causes those lesions? We don't know. It's probably this inflammation in some way getting into the skin and causing this erythema nodosum. So this is another parasarcoidosis syndrome. Often these people have bad ankle arthritis. That's usually the main problem they have. And on X-ray, they have swollen lymph nodes. These do contain granulomas, bilateral hyaluronidopathy. They often have fever as well. Again, Dr. Meyer talked about this. Small fiber neuropathy is another important parasarcoidosis syndrome. This causes a lot of problems for sarcoidosis patients. It may occur in up to a quarter of sarcoidosis patients where there is basically dropout or loss of these small fibers that we have that go into our skin. And they can cause pain. They can cause a lot of pain. It's usually a burning pain or a shocking pain. Sometimes it's in the fingers and toes, but it can be on the face, anywhere. And sometimes you can even get an autonomic neuropathy where the nerve dropout is not in the skin, but it affects the heart, causing a rapid heart rate or slow heart rate or sweating. Some people have excessive sweating from sarcoidosis. Again, it's not granulomas doing that. It's something, probably systemic inflammation getting into the bloodstream and eventually damaging the nerves. People can even have bladder, bowel, or sexual dysfunction from this as well. We don't know what causes this. This is obviously a bunch of gobbledygook, and my one picture slide doesn't make any sense, sorry, but the idea is that these are all levels, blood levels of inflammatory mediators. These granulomas are spewing out this stuff into the bloodstream. It's somehow getting to the nerves, attacking the nerves, damaging the nerves, and causing the small fiber neuropathy. And actually, you can actually make this diagnosis by biopsying the skin. This is normal skin. These are the nerves that we all have that should be percolating in through our skin. And when they get the small fiber neuropathy, there's dropout. You can't see any of those nerves over on the small fiber neuropathy picture. There are other parasarcoidosis syndromes where we know even less about than the ones that I went over. We know a fair amount about, but fatigue. A large number of patients with sarcoidosis have fatigue, and we think a proportion of them have it as a parasarcoidosis syndrome. It's coming out of the inflammation from the granuloma causing fatigue, but we don't exactly know what causes it. There's even, somewhat controversial, but most people think there is a cognitive decline, some thinking problems that can happen in sarcoidosis. And there are other non-small fiber neuropathy pain syndromes that also can occur. So when I evaluate a patient with fatigue is a common problem in sarcoidosis. And again, it's one of these parasarcoidosis syndromes. And really, fatigue, I break it down into two different types of fatigue. There's fatigue in sarcoidosis that can be due to a number of things that often problems that sarcoidosis patients have. And then there's direct fatigue from sarcoidosis, which I call sarcoidosis-induced fatigue. Now, the first type of fatigue has many causes. Sleep disorders, obstructive sleep apnea. That's very common in sarcoidosis because that's common in obese people. And what do steroids do? You all know what steroids do. So they make people gain weight. They can get obstructive sleep apnea. Once they get that, that can make them quite fatigued because they're not sleeping properly. So they wake up in the morning, they haven't had a refreshed night of sleep, and they're fatigued all day. Another problem is adrenal insufficiency. Well, I wish I could go through all these. Adrenal insufficiency, where when someone's on steroids, some of you have probably had the experience, it's great that you get tapered off steroids, that's what we're trying to do, but sometimes you get a steroid withdrawal. Who's had that? You get really fatigued. So that's another thing you have to look for in patients with fatigue and sarcoidosis. Thyroid disease, sarcoid can affect the thyroid gland and cause fatigue. Depression. Depression occurs in a sizable number of sarcoidosis patients, and we need to try to identify that because a lot of people, their manifestation of depression is fatigue, when really it's depression. And finally, they can have sarcoidosis-induced fatigue where these mediators from sarcoidosis are causing the fatigue. And this is really too much, but this is basically how I work this up, or I evaluate this, is when I have a patient with fatigue and sarcoid, the first thing I do is make sure they don't have a sleep disorder. And I do a workup for that. If they have a sleep disorder, I do polysomnography is a fancy word for sleep study. I do a sleep study, and if it's positive, I treat the sleep disorder. If they don't get better, then I'm done. I monitor them. If they don't get better, then I look at these other causes of fatigue, which are adrenal insufficiency, as I talked about, insomnia, maybe from too much steroids. Who's got insomnia from steroids? Yeah, so too much steroids, that can make you fatigued. Hypothyroidism, looking at the thyroid gland, mood disorders. If any of those conditions are present, I treat them. And if they don't get better, then I go into this yellow boxes where now I try to do my best to exclude all the causes of fatigue that the patient could have other than sarcoidosis. Now I am going to try to treat what I think is fatigue caused directly, induced directly by sarcoidosis. And the treatment for that can be steroids if it's an acute presentation. If someone just developed sarcoid, they get fatigue. But chronically, for chronic management, I don't like to give steroids for that because whatever benefit they may get from their fatigue, they may get a tremendous quality of life decrease, from from this chronic steroids. Stimulants can be useful for this. Physical training and exercise are very important. And then other anti-sarcoidosis therapies can be used. So this is basically what I just said. So we do use stimulants, can be useful for this, but I think it's one of the things that I do, which is very important, is when I have a patient who has fatigue with sarcoid, and I'm going to treat them with stimulants. First, what I try to do is delve into the psychosocial history, make sure they don't have a stress or something. And also what I do is I really require the patients to go to a psychologist who's a professional, not a psychiatrist. The patients are not crazy. A psychologist to see if there's a psychological problem, depression, excessive stress. Because you don't want to be giving, I don't want to be labeled as a sarcoid Ritalin doctor, you know, where they come to me and I give them Ritalin. There may be a life stress issue that can be dealt with that will help with the fatigue. But if there isn't, you could consider giving stimulants, and these are 3 small studies showing benefits of stimulants for patients with sarcoidosis-induced fatigue. And then physical exercise, physical training is also has been shown to be very useful in treatment of this. And finally, sometimes we have to go to the biologic agents to treat fatigue and sarcoidosis. So, in summary, parasarcoidosis syndromes are common, and they cause significant problems in sarcoidosis patients. There is treatment available for these syndromes, but remember, these may not respond to the standard anti-sarcoidosis therapy. So with that, I'll say thank you. I'm going to